Well, my topic today, as you can see, is going to be about the role of repeat biopsy in lupus nephritis. First of all, we'll start with a brief introduction about the role of lupus nephritis within lupus. Then we'll move on to the main part of the presentation, and finally, I'd like to share with you the main ideas I want to convey, or that I'd like you to take away from everything I'm going to say in the next few minutes. I will try to be brief, to stick more or less to the time, And yes, before we begin, two things. First of all, what I'm going to talk about doesn't have much evidence behind it. It's kind of a no man's land, so we shouldn't take the articles or what I'm about to say too literally, alright? In the end, this will be a phenomenon in which changes occur. Changes take place, alright? And also, just to point out that there will be paintings, and the paintings actually have meaning within the presentation, they are related to aromatology. As the presentation slide says, the numbers don't lie. Lupus nephritis affects, or there are histological alterations in, almost 100% of patients with systemic lupus erythematosus. Although of that 100%, and thank God, only approximately 50% of patients diagnosed with lupus. And lupus nephritis will go on to develop symptoms, whether analytical and/or clinical alterations. As you already know, lupus nephritis really carries a high burden of morbidity and mortality, and moreover, it is one of the leading causes of death over time in systemic lupus erythematosus. It usually presents within the first 5 years after the diagnosis of lupus, and even in a significant percentage, around 25%, that is, in about a quarter or a fifth of patients, it will appear and coexist with the lupus diagnosis. Therefore, it is a condition that must be taken seriously. And just like in rheumatoid arthritis, lupus nephritis, like lupus itself, has a worse prognosis in women of Latin American and African American descent. As for the main clinical or laboratory manifestations and abnormalities, they are the ones you see there on the screen. And I would just like to mention anti-C1q antibodies because they are sometimes somewhat overlooked in this condition. This table, you already know it. It's basically the classification of lupus nephritis. And I've included it just to emphasize that type 4, unfortunately, tends to have the worst prognosis and is usually the most common. The classification in question, divides lupus nephritis into 5 or 6 categories based on the one hand, clinical and laboratory abnormalities, or additionally, histopathological ones. And this table, simply to show that what I'm going to talk about, activity and chronicity indices within the histopathology of lupus nephritis, there's a reason for it. That is, when pathologists examine the various abnormalities under the light microscope, they rely on the items we have here on the screen. Simply, to understand what can be taken from this particular table. And why talk about the role of rebiopsy? That is, why am I here now talking about biopsy? Or rather, the repetition of the biopsy in lupus nephritis. Basically because, as you can see on the screen, almost 40%, that is a third of the patients, will not fit the prototype we see in clinical practice. That is, maybe in lab tests we see that they have an active sediment, a bit of proteinuria, but if we perform a biopsy, that patient is in remission. I mean, in remission in the sense that there is no inflammatory activity. There's only chronic damage. These are residual changes after previous activity in lupus nephritis. And conversely, there will be patients in whom we don't find any abnormalities in lab tests or clinically, but if we perform a biopsy, that biopsy will show activity indices and therefore will gradually lead to chronic kidney disease, which in turn will add to the patient's morbidity and mortality. Therefore, the rebiopsy, it can be considered a tool. It's true that it's quite invasive and we all know it comes with post-operative complications. But does it really have a place in the management of lupus nephritis or systemic lupus erythematosus in clinical practice? To enable more precise and more personalized medicine, that's what I'm going to try to talk about here today, even if it's just to give a brief overview. And after giving it some thought and looking through some papers, or even considering other topics to discuss in this presentation, basically we largely rely on analytical markers and urine sediment, right? That is, elevated anti-DNA, decreased complement levels, active sediment, proteinuria, etc. But do you really think these markers are reliable with the frequency or reliability that we attribute to them? In other words, do you think they truly reflect in the vast majority of patients the renal activity seen at the histopathological level? Well, that's another doubt, another question that I'm also going to try to address. So, to get started, here we have an article published in 2017 by Anna Malvar and colleagues. Anna Malvar, well, I imagine that those of you who have been around longer will recognize the name. She's kind of the Pope, one of the leading experts in lupus nephritis. And in this prospective study, what she does is take and compare histological changes with clinical and laboratory manifestations in patients diagnosed with lupus nephritis in remission, but of the proliferative type. Basically, it's a prospective study of approximately 70 patients, and what it does is include patients who meet the ACR criteria for systemic lupus erythematosus and who are also experiencing their first onset of lupus nephritis. And basically what she does is perform an initial biopsy on all of them, and then on average 6 months later, in those with proliferative forms, which are generally the ones with a worse prognosis, she repeats the biopsy and compares the results. And what do we get from this? Well, honestly, it's true that the sample size isn't very large, but the results really surprised me quite a bit. Basically, because if we look at the first premise they present, it's that in patients with lupus nephritis who meet criteria for complete clinical remission at the renal level, as well as those with partial or no remission, there are no statistically significant differences between the two groups in terms of complement levels, anti-DNA antibodies, or urinary sediment. In other words, we need to be careful. We can't rely categorically or confidently on these markers in most patients, as some cases will slip through the cracks. And here again, it's confirmed what I mentioned at the beginning, right? That 30–40% of patients in whom the clinical presentation does not correlate with the histology. And here it happens again. If we take a look, among the patients who are in clinical renal remission, there's a percentage, yes, 50%, who have an activity index below 3. In other words, they have almost no activity. But be careful, because 30%, as I mentioned earlier, will still have activity indices even though they are in complete clinical renal remission. That is, analytically they would be in remission, but at the histological level, there is still activity. And one of the conclusions they reach is that 6 months on average might be too short a time to repeat the biopsy in lupus nephritis. And one of the reasons they propose this is basically because, the onset of activity in the second biopsy does not appear as a significant predictive factor, for renal function. This is the table, or one of the tables, with the results they use in their article, and as you can see, both complement levels and anti-dsDNA levels, when compared in patients who are, on one hand, in complete renal remission versus partial or no remission. Watch out, there are no statistically significant differences. So be careful. This Kaplan-Meier figure, basically, what the authors are saying is that patients in whom it takes longer to perform a rebiopsy, a second biopsy, tend to have a better prognosis. But that just makes common sense, doesn't it? I mean, if we take longer to repeat the biopsy, it's usually because they tend to have a milder or much more manageable form of the disease, less pathological burden, they tend to stay in remission longer, so we need more time before they might require a second biopsy due to increased activity or a flare-up of the disease. And on the other hand, patients who undergo a rebiopsy sooner would have a worse prognosis for exactly the opposite reason. Once again, Anna Malva in this diagram here, she proposes something a bit different and revolutionary. It's true that the study is a bit older, the diagram, but what she and her collaborators propose is, hey, patients who have been in clinical remission for 2 years since induction treatment for the lupus nephritis in question, we can consider after 2 years the possibility of reducing or stopping medication by repeating the biopsy. Well, that would be a possibility, right? It's true that especially the senior physicians with more experience in the field of rheumatology know that systemic lupus erythematosus is quite treacherous. Right now it's under control, okay, but maybe over time, by reducing or stopping medication, we could have a flare-up. But it's a new or potential way of working innovatively within clinical practice. That is, after 2 years in remission, consider repeating the biopsy and de-escalating or discontinuing medication. And what do the guidelines say? Well, our main guideline, which is from the Spanish Society of Rheumatology, gives some brief and rather concise recommendations. Basically, I have to say that almost all the guidelines, and to avoid repeating myself too much, say more or less the same thing. But it is true that the ones from the Spanish Society are among the most comprehensive. They conclude that the main criteria for performing a rebiopsy would be patients who, while in clinical remission primarily, begin to show activity in the urine sediment, analytical abnormalities, or even clinical symptoms. Patients who, as I already mentioned, have a mildly abnormal urine sediment, more or less mild proteinuria, minimal analytical abnormalities. What I want to see is whether those abnormalities are chronic or, on the contrary, if there is histological activity in order to optimize the treatment. And as Ana Malva pointed out, it's true that the Spanish Society doesn't specify an exact date or time frame, but they do suggest or recommend that in patients who have been in clinical remission for a certain period, it's worth considering repeating the biopsy to de-escalate treatment. And be careful, not every renal abnormality in lab results or in the urine sediment of a patient with lupus is necessarily due to lupus nephritis. That is to say, keep in mind that these patients often have significant comorbidities, mainly cardiovascular risk factors and nephrosclerosis, which can also affect filtration and alter lab results. For example, these patients may also have associated APS, antiphospholipid syndrome, or even mixed connective tissue disease. So caution is needed. And medication, NSAIDs, since pain is ultimately one of the main symptoms these patients experience. You have to be careful because analgesic overuse, what is it associated with? Well, aside from papillary necrosis, which is somewhat more severe and considered its most serious manifestation, it's also linked to tubulointerstitial disorders. And we've talked here about delta acrolimus. Be aware that calcineurin inhibitors are also associated with nephrotoxicity and can also contribute to the decline in renal filtration. Therefore, a biopsy would also be useful in these situations to help stratify and determine whether the issue is truly due to lupus nephritis or other causes. The Spanish Society of Nephrology is much more concise, and I'd just like to highlight that while Ana Malvar suggests 2 years of clinical remission following induction therapy, the Spanish Society of Nephrology proposes allowing a margin of 36 months. Well, it's another alternative. What does KDIGO say? Well, they are even more concise. If you ever take a look at the guidelines, if you feel like it, you'll see that it's actually a very brief paragraph. They hardly dedicate any time to rebiopsy within the context of lupus nephritis. And what they establish is that we should allow a margin of 2 months for patients when starting a treatment to assess whether it is effective or not. However, be careful. As you can see here, 60% of patients who may experience treatment failure could be due to poor therapeutic adherence. Therefore, before considering a rebiopsy or a change in medication, always make sure that therapeutic adherence is adequate. And well, recently, as some of my colleagues have mentioned, the ACR took place in Washington. There, in addition to new recommendations for the treatment of lupus nephritis, some insights were also shared regarding their recommendations on when to perform a biopsy. Not so much about rebiopsy, but rather about biopsy in general. And well, regarding the part that concerns me in this section, it's simply that I want to refer to the part that's in red, right? The little red box, which basically refers to performing a biopsy in patients who are in clinical remission, and then suddenly show new abnormalities in their urine sediment in lab tests or at the clinical level. Or also, just as KDIGO stated, that 2 months was the optimal time to assess whether there was effectiveness or not, patients who continue to have persistent abnormalities in the urine sediment or lab results for more than 6 months should also be considered candidates for a biopsy to determine whether the treatment is truly ineffective or are they really residual alterations. And I got in touch with Dr. Rudrapan, an Indian rheumatologist, who presented a very interesting poster at the ACR, and I asked him for permission, and he told me, of course, I could use it for this congress. And what he basically did was, in patients with lupus and systemic dermatosis, and with lupus nephritis, they were rebiopsied. Almost 100 of those 600 patients. And something quite curious was observed. which is that we need to forget, or at least I used to think this way, that lupus nephritis is not static. In other words, the type of histology does not remain the same over time. It is dynamic, okay? If we look closely, almost 75% of the rebiopsied patients undergo a transition, okay? Almost 80% of those originally classified as type 2 progress to a proliferative form, note, with a worse prognosis. And similarly, from type 5, the membranous form, nearly 50% progress to a proliferative form, again, with a worse prognosis. This is the poster in question, which is actually very visual. I do think it looks much better on the screens. Here, the color is a bit lost, but as you can see, there are changes, meaning it's not static, it's dynamic. There are patients who start with non-proliferative forms and progress to proliferative forms. The reverse is much less common, but there are also mixed phenotypes, which again worsen the prognosis. The time between the rebiopsies was approximately 6 years. And what were the main reasons for the rebiopsy? Well, mainly to assess the activity or chronicity indices in the histology in the kidneys in patients with nephrotic syndrome, or patients who are in remission, just as stated by the Spanish Society of Rheumatology, or for example, Ana Malvar, to assess whether they are in clinical remission and whether to de-escalate or discontinue medication. And now, to start wrapping up a bit, this is a study that is currently underway, and I believe it will finish around the end of 2025. The researchers are taking patients, the study is called Review Loop, and basically they select patients with lupus nephritis who meet the diagnostic criteria for systemic lupus erythematosus, randomize them, and divide them into 2 groups. And I should mention that the treatment used for each patient is the one applied in clinical practice, meaning there is no standardized treatment or specific drug involved. Instead, each patient is treated individually, just as they would be in a hospital consultation. And what they do is, after 12 months, one group simply undergoes a standard follow-up consultation. However, in the other group, in addition to the follow-up consultation, a rebiopsy is also performed. The biopsy is repeated. And at 24 months, they assess the outcome. And what is the primary outcome? To determine the percentage of patients who achieve complete renal remission. Why? Because what is their hypothesis? Well, the hypothesis of these researchers is that the patients in the rebiopsy group will have a higher rate, a higher percentage of complete renal remission. Why? Because in the end, we are providing a much more specific and targeted treatment. We're actually seeing what's happening inside that black box, that is lupus nephritis. So that's basically the study, and honestly, it will provide quite a lot of valuable information, right? About the use of this technique within rheumatology. And regarding the conclusions, well, as I mentioned briefly at the beginning of the presentation, lupus nephritis is one of the main extra-articular manifestations of lupus. And it also carries a high burden of morbidity and mortality, being one of the leading causes of death among patients. The main clinical parameters, anti-DNA, complement levels, etc., are not always as reliable as we might think. Therefore, there will be a not insignificant percentage of patients in whom we must suspect that even though the parameters appear to be improving, if the patient reports symptoms or is experiencing any kind of discomfort, we should consider that there might be something more going on. On the other hand, as I've tried to emphasize throughout the presentation, the role of the repeat biopsy allows us to practice precision medicine, helping us to optimize treatment and avoid exposing patients to potentially toxic medication unnecessarily, or conversely, to determine whether we are under-treating or over-treating. And always, before concluding that the treatment is ineffective or that the disease is resistant to treatment, always assess therapeutic adherence. In a significant percentage of cases, as you've already seen, lupus nephritis is dynamic. In a significant percentage, it progresses from non-proliferative to proliferative forms. Be careful, again, remember, that carries a poor prognosis. And well, as I already mentioned at the beginning of the presentation, evidence is scarce. As you can see, there's no consensus. It's not valid to say, look, I'll use 2 years or 36 months or find what the optimal time would be to assess refractoriness. We don't know. We have no idea. There are some guidelines that recommend one duration and others that suggest another. So basically, what I would do is use the guidelines and combine them with the clinical experience of each of you here present. And well, I would like to pose a question, especially regarding these kinds of novel approaches, particularly to the senior physicians with more experience. If you had a histology with, above all, low activity but significant chronicity, would you consider withdrawing medication? A patient with lupus nephritis who has been in remission for 2 years? Well, that's all. I just want to thank you for being here today and express my gratitude.